These little kids with difficulty breathing and fever. We see these sort of non-specific findings. He's definitely hyperinflated, right? Look at the diaphragms are down. This is the reading from the radiologist. Streaky right upper lobe opacity may reflect atelectasis or developing pneumonia. Right? Right? So when you look at a film like this, I'm not wildly impressed with this. And this is one of those reasons why I don't tend to get x-rays on febrile kids with asthma who are coughing a lot. Okay? If you get it, it's okay, but what are you going to do with this? He's not taking his amoxicillin. You're going to admit him and put him on ceftriaxone? I mean, it doesn't, you know. So when I went in and listened to this kid, he was wheezing, right? And he'd been giving him albuterol every 4 hours for the last 3 days, and it was helping, but then he would start coughing again. Symptoms were also worse at night, keeping everyone up, which is part of the reason Dad was so unhappy, right? And so, in this case, the history really helped a lot. You know, we didn't hear any coughing or any wheezing on the initial exam. I'm quite sure my fellow did not hear wheezing, that the kid wasn't wheezing at the time. But again, these things come and go, right? I'm sure you guys have had kids where you listen once, you're like, oh, there's wheezing. And then 5 minutes later, you listen again, like, wait, where'd that wheezing go? Now they got crackers, right? So sometimes the history helps you more than your physical exam, right? So we sent this kid home, we gave him a shot of Decadron because he was being a brat, not taking oral medication. And we sent him home as a viral infection. Dad did not have to give any more amoxicillin. Okay? That's a problem with diagnosing pneumonia, right? As people who are parents know, giving medicine to kids sucks. It's really hard to do. Kids do not like the taste of some of these medicines. We see kids coming in with rashes after being started on antibiotics, with diarrhea, right? Sometimes the cure is worse than the disease. And so that's why, you know, and that's why the IDSA guidelines are, don't routinely treat these kids with antibiotics, because most of them are viral processes, okay? If this kid had a big, ugly looking pneumonia like the kid in case 2, I would treat them. I might, if the kid's really not taking antibiotics, I would admit him and put him on antibiotics. I would also, with what Dad is telling me, I would also give him steroids, okay? All right, treatment of asthma exacerbation. So, I'm just going to go over a couple of our the treatment options. I think I have some slides on magnesium as well. Systemic steroids are really key for asthma exacerbations. Right? They speed resolution of airflow obstruction. They potentiate the effects of beta-2 agonist therapy, so they help albuterol by upregulating smooth muscle beta agonist receptors. The onset of action is 1 to 3 hours. All right, so you want to give them early. Study after study has shown that giving steroids to kids decreases duration, decreases severity of asthma exacerbations. Effects of PO and IV administered steroids are equivalent. So don't feel like you have to put an IV in a kid with who's wheezing pretty bad or having pretty significant side effects. If they're working so hard that you think they won't even be able to tolerate oral, okay, put an IV and give them Cytomedrol. But it's not going to work faster than the Decadron, right? Systemic steroids, again, all these studies show better outcomes when you give steroids. There were 2 studies out of Canada a couple of years ago which were really helpful in that they showed early administration of steroids during the ER visit decreases admission rates. Okay, we have a policy in the ER where our nurses can give steroids at triage to kids with asthma. I don't know how well we do with that, but we need to, especially in the busy months of winter time when we see a lot of these kids. If you give steroids early, within an hour, your odds of being admitted to the hospital go down a lot. So we really want to be trying getting steroids into these kids early on when they come into the ER, right? Because again, it takes 1 to 3 hours for the steroids to kick in. So if a kid's been in your ER for 3 hours and they haven't gotten steroids yet, it's going to be another 3 hours before they start getting better, by which time people are going to be like, hey, maybe we should just admit this kid, right? So we've got to get them early. When to give steroids? So again, like in our first case, you know, take into account the medical history. Has he done this before? Has he responded to albuterol before? Is there a family history consistent? And also consider HPI. So we'll see a lot of kids come in and they sound clear on exam. And the story, the parents say, well, he has asthma, and he has a cold, and he's been coughing his head off and wheezing for the last 3 or 4 nights. And you go in the room, you listen to him, and they sound clear. That, for me, that's an asthma exacerbation. He may not need albuterol, but he needs steroids. You need to give him steroids to shorten the course, so mom doesn't have to get albuterol as often. So when you see us in the ER, even this kid who's running around the room not coughing, steroids, that's part of the idea. I don't want him coming back sicker tomorrow with the symptoms. Are they safe? There's this kind of, I think, in our reptilian medical brains that steroids are dangerous. If you give a kid with fever steroids, are you going to send them into septic shock because you're going to suppress their immune system? And that's not the case. If a kid is on chronic steroid therapy for their nephrotic syndrome or whatever, and they get a fever, those kids can get really sick. They can get adrenal insufficiency and stuff like that. So in this case, when you give 1 or 2 doses of Decadron, you're not going to suppress their immune system. So even if they have a fever, then you can absolutely give a short course of steroids. Again, I said 5-day courses back from the days when we were doing prednisone. We're actually doing a lot more Decadron now, I think almost exclusively in our ER, and that's become kind of a trend around the country. So dexamethasone, in the past 10 years, there was, I don't have a slide on it, but there was a meta-analysis out of pediatrics a few years back. There have been 6 trials on comparing Decadron to Orapred for kids with asthma. The problem is that some of the studies did 1 dose of Decadron, other studies did 2 doses of Decadron. And the conclusion of the authors in this paper in pediatrics was 1 or 2 doses of Decadron is the equivalent of 5 days of Orapred. Okay? And so if I have a kid who's mild, like the kid who's running around the room who's been coughing for the last few nights, I'll give them 1 dose of Decadron. If I have a kid who I'm really concerned about, they had a bad exacerbation or they get very frequent exacerbations, I'll do 2 doses. We don't have the data yet to know is 1 exactly equivalent of 5 days of Orapred or not. Okay? So that's why the nurses from the ER sometimes will give a dose of Decadron for home, sometimes we won't, and that probably varies among physicians. Yeah?
So, Jim, are we going to see a trend more in admitted asthmatics to going to the second dose of Decadron if they got 1 in the ED?
Do they send them home with Orapred? Is that kind of more what happens?
It seems like once they get to the floor, they get switched to prednisone and
Prednisone?
they go home with prednisone.
Yeah, I would suggest yes. I don't know. I don't really think there's Decadron lasts longer, right? So the question in my mind, which I don't think has been answered, is when do you give that second dose, right? I guess ideally I would give it not the next day, but the day after. I think that's confusing maybe to parents, and so I sort of just say, give it tomorrow or tomorrow evening or something, right? And so I don't know when the ideal time to give that second dose is, but I don't know exactly what the algorithm on the floor is going to look like. But I would suggest a second dose of Decadron because then you don't have to give the kid more medicine that they might spit up or that the parents aren't going to get the prescription for. That's the great thing about Decadron. Studies have shown kids with asthma and kids with any medical condition or adults, when you give them these prescriptions, a lot of times they don't go to the pharmacy and fill them up. Right? So when you give this kid 4 days of Orapred to go home with, there's a good chance that they're not going to fill out the prescription. So if I can give 1 dose of Decadron and be done with it, then I've ensured adherence to the care regimen. So yeah, I would suggest 5 minutes. Okay. All right, so I'm going to quickly run through a couple more things. So steroids, fever, okay. Albuterol-Dosing, MDI, study after study shows MDI works with spacer, works better than nebulizer. And so we prefer to send kids home with albuterol MDI. They need to know how to use the spacer, and you need to tell them you've got to use the spacer every time. Even teenagers, you've got to use your spacer. The delivery is much better. If you're having trouble breathing, you do one of these old-timey things where you just put it in your mouth and do that. A lot of that is going to end up in the back of your throat, on the top of your mouth, not in your lungs. You need the spacer. Okay? Albuterol has some side effects, but overall it's extremely safe. So when the parent's like, his heart's beating like crazy, that's okay. All right? If he's got palpitation, parents get worried about the tremors as well. So let them know what the side effects are. It's an extremely safe drug. Okay? The reason we use ipratropium bromide, anticholinergics, is for the following. Ipratropium or Atrovent is a weak bronchodilator. It doesn't bronchodilate that much, but it bronchodilates in a different mechanism than albuterol. So it has an additive effect to your albuterol therapy. It's not indicated for use by itself in children. Rarely the pulmonologists, when they have kids with certain conditions, will give Atrovent, but not routine. So we don't send kids home with Atrovent routine. And it's been shown to be effective in moderate, severe attacks of asthma. It also reduces hospitalizations. Okay? There was a study out back in the 90s where they looked at 3 doses of Atrovent versus 1 dose of Atrovent versus placebo. And they found the 3 doses worked better than the 1, worked better than the 0. So that's where we come up with these 3 doses of Atrovent. The dose they used was 250 mics per dose. The recommendations are 250 to 500 mics times 3 in kids with moderate to severe asthma. And so that's why in the ER we've gone from our old 250 or 500 micrograms to 1,500 micrograms for all. Okay? And the pulmonologist, Atrovent is a very safe medication. So our pulmonologists would recommend, in kids it's 250 to 500 times 3, in adults it's 500 times 3. Just for simplicity, the pulmonologists just give everyone 500 times 3 or 1,500 micrograms. And so that's been a change that we've been doing over the past 6 months or a year. Okay? All right. All right, so I'm just going to go to magnesium. We are going to continuous albuterol. We're doing 15 to 20 milligrams per hour. In the ER, 15 for kids with moderate asthma on your MPAS score, 20 for the severe. Okay? And around the country, there are different, I don't think anyone knows what the exact right dose is, but it's more than we've done in the past. We used to do 2.5 times 3, and that gives 7.5 milligrams an hour. We're doing a lot more albuterol. Okay? Magnesium, the mechanism of action is unknown. Proposed mechanisms: prevention of bronchiosmooth muscle contraction via whatever. Who cares? Stabilization of T cells and mast cell membrane. So it's been shown in multiple studies to decrease hospitalizations. Okay, this is a meta-analysis looking at 5 randomized controlled studies in children, 10 in adults. These are small studies, so I mean, it'd be nice if we had like a PCARM study of like 6,000 kids with asthma. We don't have that yet. But the thought is that it can reduce hospital admission. Traditionally, the way magnesium is used here and at my old institution in Columbus, Ohio, is we give magnesium when we think the kid's going to the PICU, right? So it's once we made the decision to admit, that's when we give magnesium. That's not the way we should be doing it. We should be doing it in the kids who were like, oh boy, this kid might get admitted, let's give him magnesium and try to get him home. And so it works for some, it doesn't work for others, but it's very safe. Okay? And so the way it's been used in studies is you give albuterol for an hour, and if they're still looking like they're going to get admitted, that's when you do the magnesium. In the ER here, if we have a severe asthmatic, we're saying you can do the magnesium right when they come in, and I think that's very reasonable. But we should be doing magnesium on all these kids who are concerned are going to get admitted to the hospital, and as a way to try to get them home. Okay? Doesn't work on everyone. It's 50 milligrams per kilo. You get it over 20 minutes. It's well tolerated. People get worried about hypotension. I don't routinely give bolusing with magnesium because I've not seen kids get really hypotensive at all. But you might see doctors say, oh, we have to give a bolus with magnesium. That's a common thought, is you need to give IV fluid boluses with magnesium, and I don't have a problem with that. I just don't think you necessarily have to do it. Okay. Try to avoid intubating. Intubating is, managing these kids intubated is very difficult, and it can have lots of complications, including pneumothorax and death, which is not good. Intubation, if you're going to intubate them, use ketamine. Ketamine is a bronchodilator, and so that's typically what we'll use if we're intubating, but luckily we hardly ever intubate anymore for asthma. So take-home points, 5 important questions. Has he ever wheezed, had breathing problems in the past? Does he have atopic dermatitis or allergies? When he's not sick, does he ever cough at night to the point of waking up? When he's not sick, does he ever cough or wheeze when he runs around? If so, multiple choice test. Is there any parental history of asthma? Aunts and uncles and grandparents? I really want to know, Mom, Dad, do you have any history of asthma? And of course, is there any smoking exposure? The differences between bacterial and viral, this can really help you in terms of, what should we be doing with this kid? And again, you're going to see a lot of x-rays on these kids, and if you ask the residents how often they see a really impressive lobar infiltrate on these kids, they're going to see very few times, right? If you see it, then by all means treat with antibiotics, because we don't want to miss a bacterial pneumonia. But most of these kids will have streaky, non-specific stuff that the radiologist may read as atelectasis versus pneumonia. In those kids, I do not routinely put them on antibiotics. Think of asthma in young children with repeated episodes of difficulty breathing, repeated episodes of pneumonia. If they're having croup all the time, I think croup sometimes gets, it's worse at night. It makes the kid have difficulty breathing, and it gets better with steroids. And so I think sometimes kids with asthma would be called croup over and over again. Cough that is worse at night, disrupts sleep, lasts for weeks. You get a cold and they're coughing for weeks at a time with nighttime awakening, post-tussive vomiting. Diagnosis of infant young child with recurrent wheeze is in the form of treatment. We trial and error. So I'm giving out lots of albuterol and steroids to kids. I'm not sure it's going to help. Mom, this is a trial. Let's see if it helps. If it doesn't help at all, okay, then it's probably just a worry, viral wheeze, right? If you notice a rapid improvement, the kid's a lot better in the next 24 hours, okay, just keep that in the back of your mind. If it starts happening over and over again, you have more information to tell your doctor that, boy, it really seemed like the albuterol and steroids helped the last time it happened, and he's doing the same thing again. And that can help to move along the workup and the diagnosis. Okay? If they don't respond, then we need to figure out if there's something else going on. Okay? Any questions? Yeah.
Just kind of a general question. For paramedics in the field, what do you see, if any, as our place in this process, other than digging into that history?
I think the history is a really important thing, and if you notice they're in respiratory distress, I don't think you guys do antibiotics on these kids routinely. You will try albuterol, which I think is the appropriate thing. The whole thing with albuterol and viral wheezing is, in the past, we admitted tons and tons of kids, and we put them on these albuterol weaning protocols. It's not helping anyway, right? And then we prolong hospital admissions, and so that's why we want to try to not be overly aggressive with the albuterol, especially in January and February when RSV is prevalent, and especially in the younger children. But I think on a case-by-case basis, we need to think about it a little bit more. So if you have a 6-month-old with eczema all over their body and the third episode of wheezing, we should probably give a trial of albuterol to this child. And if you have a kid, I think the 2- and 3-month-olds, I would say you probably don't need to do albuterol on the way in, unless you get these really outstanding stories, right? So I think that can help you guys in terms of how aggressive you be with albuterol. Okay? Any other questions? Yeah?
If the child has sickle cell, would it change?
So in terms of giving steroids? Oh, well, yes, it does change. So fever and sickle cell is different, right? Acute chest is different. So yes, I'm going to be much more careful with the kid with sickle cell who has a fever and a cough and difficulty breathing than I am in a kid who doesn't have sickle cell. Actually, there's evidence that kids with sickle cell are more likely to have asthma, which is terrible. But yes, it definitely changes, right? So I'm going to get an x-ray on a kid with sickle cell. I'm going to talk to the hematologist. I think most of the time they would say yes, if they have asthma, give steroids, give albuterol, but we probably need to admit that kid and make sure that they don't develop acute chest. So yes, it does change it. Yeah?
So for discharging, I noticed patients will go home with 2 cups of albuterol. In my previous practice, every kid, this is coming from the Midwest, would go home with 4 puffs. And I noticed on your slide it said 4 to 8.
So I didn't go through that thoroughly. 4 to 8 puffs, we don't know what the right dose is for an acute exacerbation. In the ER, though you see things in the literature up to 12 doses or 12 puffs every 20 minutes, right? I don't know if you're in your own hospital, did you guys do inhalers in the ER for routinely?
It kind of varied depending on what
Attending, yeah.
triage and,
Yeah. So I mean, so there are ERs in the country who will, and for the less severe asthmatics, they'll just give them inhaled albuterol in the ER, right? Because it's better than the nebulizer, and it sort of reinforces, hey, we want you to use the inhaler, not the nebulizer. We're not at that point here, and actually we weren't at that point in my old hospital. But yes, you're exactly right. I have actually started to move from 2 puffs, which I've been saying for 15, 20 years, to 2 to 4 puffs. I'm kind of moving up there, and I think bigger doses is probably appropriate for most of these kids, because I think 4 puffs is not that much. It's just kind of ingrained in us that it's 2 puffs every 4 hours. That's what we've always said. I'm starting to move forward, and I need to actually talk to the pulmonologists. I think they usually recommend more too. So, any other questions? Thanks, guys.
Sure.